ACLS Practice Test 2025 Part 3 Bradycardia and Tachycardia.
Question 1. What heart rate defines bradycardia in the ACLS algorithm? Option A, less than 60 bpm. Option B, less than 50 bpm. Option C, less than 40 bpm. Option D, less than 70 bpm.
The correct answer is option B, less than 50 bpm. In the ACLS framework, bradycardia is typically defined as a heart rate less than 50 beats per minute.
Question 2. What is the primary criteria for determining if a bradycardic patient is unstable? Option A, the exact heart rate on the monitor. Option B, presence of symptoms like hypotension, altered mental status, or ischemic chest pain. Option C, the patient complaining of a mild headache. Option D, a prolonged PR interval on the ECG.
The correct answer is option B, presence of symptoms like hypotension, altered mental status, or ischemic chest pain. A patient is considered unstable if the bradycardia is causing severe symptoms such as hypotension, acutely altered mental status, signs of shock, or ischemic chest pain.
Question 3. What is the first-line medication for symptomatic, unstable, bradycardia? Option A, epinephrine 1 mg. Option B, atropine 1 mg. Option C, dopamine 5 mg/kg/min. Option D, amiodarone 150 mg.
The correct answer is option B, atropine 1 mg. Atropine 1 mg forepush is the first-line medication for unstable bradycardia. It can be repeated every 3 to 5 minutes up to a maximum of 3 mg.
Question 4. If a patient with symptomatic bradycardia does not respond to atropine, what is the next appropriate step? Option A, administer adenosine. Option B, perform synchronized cardioversion. Option C, initiate transcutaneous pacing, TCP, or a dopamine/epinephrine infusion. Option D, administer amiodarone.
The correct answer is option C, initiate transcutaneous pacing, TCP, or a dopamine/epinephrine infusion. If atropine is ineffective, the next step is transcutaneous pacing, TCP, or a continuous infusion of dopamine or epinephrine.
Question 5. What is the recommended dose for a dopamine infusion in symptomatic bradycardia? Option A, 1 to 2 mg/kg/min. Option B, 5 to 20 mg/kg/min. Option C, 20 to 30 mg/kg/min. Option D, 50 mg/kg/min.
The correct answer is option B, 5 to 20 mg/kg/min. The recommended dose for a dopamine 4 infusion is 5 to 20 mg/kg/min, titrated to the patient's response.
Question 6. In which types of AV block should you use caution when giving atropine and prepare for immediate transcutaneous pacing? Option A, first-degree AV block. Option B, Mobitz type I, Wenckebach, second-degree AV block. Option C, Mobitz type 2, second-degree AV block and third-degree AV block. Option D, sinus bradycardia with a PVC.
The correct answer is option C, Mobitz type 2, second-degree AV block and third-degree AV block. Atropine is often ineffective for infranodal blocks like Mobitz type 2 and third-degree AV block. Transcutaneous pacing should be prepared immediately.
Question 7. When initiating transcutaneous pacing, what should the rate usually be set to? Option A, 40 bpm. Option B, 60 bpm. Option C, 100 bpm. Option D, 120 bpm.
The correct answer is option B, 60 bpm. When setting up transcutaneous pacing, start with a rate of 60 beats per minute and adjust based on clinical response.
Question 8. What defines a tachycardia in the ACLS algorithm? Option A, heart rate 100 bpm. Option B, heart rate 120 bpm. Option C, heart rate equals 150 bpm. Option D, heart rate 200 bpm.
The correct answer is option C, heart rate equals 150 bpm. While tachycardia is technically greater than 100 bpm, the ACLS tachycardia algorithm focuses on heart rates equals 150 bpm as the threshold for causing symptoms.
Question 9. What is the immediate treatment for a patient with unstable tachycardia, e.g. HR 170 BP 80/50 altered mental status? Option A, administer adenosine 6 mg. Option B, synchronized cardioversion. Option C, defibrillation at 200 J. Option D, administer amiodarone 150 mg.
The correct answer is option B, synchronized cardioversion. Immediate synchronized cardioversion is the treatment of choice for a patient with unstable tachycardia.
Question 10. Which intervention should be considered before synchronized cardioversion if the patient is conscious and time permits? Option A, administering a bolus of propofol or midazolam for sedation. Option B, administering epinephrine. Option C, performing a precordial thump. Option D, placing the patient in the prone position.
The correct answer is option A, administering a bolus of propofol or midazolam for sedation. If the patient is conscious and time permits, you should administer sedation before performing synchronized cardioversion.
Question 11. A patient has a stable narrow-complex regular tachycardia. What is the first recommended intervention? Option A, vagal maneuvers. Option B, adenosine 6 mg rapid 4 push. Option C, synchronized cardioversion. Option D, amiodarone infusion.
The correct answer is option A, vagal maneuvers. For a stable narrow-complex regular tachycardia, the first step is to attempt vagal maneuvers, e.g. Valsalva maneuver.
Question 12. If vagal maneuvers fail for a stable narrow-complex regular tachycardia, what is the appropriate medication and dose? Option A, adenosine 12 mg 4 push. Option B, adenosine 6 mg rapid 4 push. Option C, amiodarone 150 mg over 10 minutes. Option D, atropine 1 mg.
The correct answer is option B, adenosine 6 mg rapid 4 push. Adenosine 6 mg rapid 4 push followed by a normal saline flush is the first pharmacological treatment for stable SVT.
Question 13. If the first dose of adenosine is ineffective, what is the second dose? Option A, 6 mg. Option B, 12 mg. Option C, 18 mg. Option D, 300 mg.
The correct answer is option B, 12 mg. If the SVT does not convert after 1 to 2 minutes, a second dose of adenosine 12 mg rapid 4 push can be given.
Question 14. What must you do when administering adenosine? Option A, push it slowly over 2 minutes. Option B, administer it intramuscularly. Option C, push it rapidly and follow immediately with a 20 ml saline flush. Option D, mix it in a 500 ml bag of normal saline.
The correct answer is option C, push it rapidly and follow immediately with a 20 ml saline flush. Adenosine has an extremely short half-life, so it must be given as a rapid 4 push followed immediately by a rapid saline flush.
Question 15. A patient presents with stable wide complex tachycardia. Which medication is appropriate? Option A, atropine 1 mg. Option B, adenosine 6 mg, if regular and monomorphic. Option C, epinephrine 1 mg. Option D, dopamine infusion.
The correct answer is option B, adenosine 6 mg, if regular and monomorphic. For stable wide complex tachycardia, adenosine can be considered only if the rhythm is regular and monomorphic. Otherwise, antiarrhythmic infusions, like amiodarone, are used.
Question 16. What is the loading dose of amiodarone for a stable wide complex tachycardia, e.g. stable VT? Option A, 300 mg 4 push. Option B, 150 mg 4 over 10 minutes. Option C, 1 mg per minute infusion. Option D, 6 mg rapid 4 push.
The correct answer is option B, 150 mg 4 over 10 minutes. For stable VT, the amiodarone dose is 150 mg infused over 10 minutes, not a rapid push like in cardiac arrest.
Question 17. What is the recommended energy setting for synchronized cardioversion of a narrow regular rhythm, SVT? Option A, 50 to 100 joules. Option B, 120 to 200 joules. Option C, 200 joules. Option D, 360 joules.
The correct answer is option A, 50 to 100 joules. The recommended initial energy dose for a narrow regular rhythm, SVT or atrial flutter, is 50 to 100 joules.
Question 18. What is the recommended energy setting for synchronized cardioversion of a narrow irregular rhythm, atrial fibrillation? Option A, 50 to 100 joules. Option B, 120 to 200 joules biphasic or 200 J monophasic. Option C, 360 joules. Option D, 10 to 50 joules.
The correct answer is option B, 120 to 200 joules biphasic or 200 J monophasic. For atrial fibrillation, the recommended initial energy dose is 120 to 200 joules on a biphasic defibrillator.
Question 19. What is the recommended energy setting for synchronized cardioversion of a wide regular rhythm, monomorphic VT? Option A, 50 joules. Option B, 100 joules. Option C, 200 joules. Option D, 360 joules.
The correct answer is option B, 100 joules. The recommended initial energy dose for synchronized cardioversion of monomorphic VT is 100 joules.
Question 20. If a patient has a wide irregular tachycardia, polymorphic VT, how should they be treated? Option A, synchronized cardioversion at 100 J. Option B, defibrillation, unsynchronized shock, at defibrillation doses. Option C, adenosine 6 mg. Option D, vagal maneuvers.
The correct answer is option B, defibrillation, unsynchronized shock, at defibrillation doses. Polymorphic VT, like Torsades, is unstable and the monitor often cannot synchronize to the varying QRS complexes. Treat with unsynchronized defibrillation.
Question 21. Why is the sync mode used during cardioversion? Option A, to deliver the shock during the T wave. Option B, to deliver the shock precisely on the R wave to avoid the vulnerable refractory period. Option C, to reduce the energy output of the machine. Option D, to sync the machine with the patient's breathing.
The correct answer is option B, to deliver the shock precisely on the R wave to avoid the vulnerable refractory period. The sync mode detects the R wave and delays the shock to avoid hitting the T wave, which could precipitate ventricular fibrillation.
Question 22. A patient with AFib with RVR has a blood pressure of 70/40 and is confused. The monitor is in sync mode but the shock will not deliver when you press the button. What is the most likely cause? Option A, the battery is dead. Option B, the machine cannot identify the R waves because they are too small, you may need to increase the gain. Option C, you must hold the button until the shock is delivered. Option D, both B and C are correct.
The correct answer is option D, both B and C are correct. During synchronized cardioversion, the machine waits for an R wave. If the gain is too low, it won't see it. Also, the operator must press and hold the shock button until it fires.
Question 23. Which rhythm is characterized by a progressively lengthening PR interval until a QRS complex is dropped? Option A, first degree AV block. Option B, second degree AV block type 1, Wenckebach. Option C, second degree AV block type 2. Option D, third degree AV block.
The correct answer is option B, second degree AV block type 1, Wenckebach. Second degree AV block type 1, Mobitz-Wenckebach, is characterized by progressive prolongation of the PR interval until a beat is dropped.
Question 24. Which rhythm is characterized by complete dissociation between P waves and QRS complexes? Option A, first degree AV block. Option B, second degree AV block type 1. Option C, second degree AV block type 2. Option D, third degree AV block, complete heart block.
The correct answer is option D, third degree AV block, complete heart block. In a third degree AV block, there is no relationship between the P waves, atria, and the QRS complexes, ventricles.
Question 25. What is the maintenance infusion rate for amiodarone after a successful conversion of stable VT? Option A, 1 mg per minute for the first 6 hours. Option B, 5 mg per minute for 24 hours. Option C, 0.5 mg per minute for the first 6 hours. Option D, 10 mg per minute.
The correct answer is option A, 1 mg per minute for the first 6 hours. Following the 150 mg bolus, the maintenance infusion for amiodarone is 1 mg per minute for the first 6 hours, followed by 0.5 mg per minute for the next 18 hours.
Question 26. Which of the following is an absolute contraindication to the administration of adenosine? Option A, tachycardia. Option B, asthma/reactive airway disease. Option C, hypertension. Option D, pregnancy.
The correct answer is option B, asthma/reactive airway disease. Adenosine can cause bronchospasm and is generally contraindicated or used with extreme caution in patients with asthma or severe reactive airway disease.
Question 27. Procainamide is an alternative to amiodarone for stable wide complex tachycardia. What is the infusion rate? Option A, 20 to 50 mg/min. Option B, 1 to 2 mg/min. Option C, 100 mg per minute. Option D, 5 to 10 mg/kg/min.
The correct answer is option A, 20 to 50 mg/min. Procainamide is infused at 20 to 50 mg per minute until the arrhythmia is suppressed, hypotension ensues, QRS duration increases greater than 50%, or the max dose of 17 mg per kilogram is reached.
Question 28. You are treating a patient with symptomatic bradycardia. You have given 3 doses of atropine, total 3 mg, but the patient remains hypotensive at 75/40. What should you do next? Option A, give a 4th dose of atropine. Option B, start an epinephrine infusion at 2 to 10 mg/min. Option C, give adenosine. Option D, perform unsynchronized defibrillation.
The correct answer is option B, start an epinephrine infusion at 2 to 10 mg/min. The maximum dose of atropine is 3 mg. If the patient is still unstable, you must move to transcutaneous pacing or an inotrope/chronotrope infusion like epinephrine.
Question 29. What is a common side effect patients experience when receiving adenosine? Option A. A sudden feeling of impending doom or chest heaviness. Option B. Extreme hunger. Option C. Uncontrollable shivering. Option D. Temporary blindness.
The correct answer is option A. A sudden feeling of impending doom or chest heaviness. Adenosine causes a brief period of azystole, which frequently causes patients to feel a brief but intense sensation of chest flushing heaviness or impending doom.
Question 30. A patient complains of palpitations. The monitor shows a regular narrow complex rhythm at 180 bpm. BP is 120/80. What algorithm should you follow? Option A. Bradycardia algorithm. Option B. Cardiac arrest algorithm. Option C. Tachycardia with a pulse algorithm, stable. Option D. Acute coronary syndromes algorithm.
The correct answer is option C. Tachycardia with a pulse algorithm, stable. The patient has a tachycardia, 180 bpm, with a pulse and normal blood pressure indicating they are stable. You should follow the stable tachycardia algorithm.